55 to 60 years of age. Patients of either sex, both male and female, were included in the study. Patients attending the diabetes clinic and patients having type 2 diabetes for less than 5 years were included in the study. Those patients who were on oral anti-diabetic treatment except insulin were included. There was no change in the anti-diabetic treatment in patient for the last 1 month. And patients who were willing to consent to writing and to follow the TRM meal plan, only they were included in the study. Patients who reported with diabetes other than type 2, they were excluded from the study. If there was any evidence of renal or liver disease, then we excluded the patient. Pregnant and lactating mothers and women intending pregnancy were excluded. If the patient had participated in any other clinical trials during the last 30 days, we excluded the patient. Patient having any history of hemoglobinopathy that may affect determination of HbA1c, they were excluded. Patients having history of cardiomyopathy, retinopathy or nephropathy were excluded. We also excluded patients using SGLT2 and GLP-1 RA. Non-volunteers, presence of any other disease which impacted nutrition, etc. Currently, those who were performing shift work or overnight shift work for more than 1 day a week and those who regularly drink alcohol were all excluded from our patients. Those being included in the study did not have any such criteria. So this was the study design. The total number of subjects recruited in the study was 350 at the start of the study, but we lost 77 patients to follow up, which made our final number 273. There were 2 groups of patients. One was the TRM group and the other was the control group. The time-restricted meal intake group had 134 patients and the non-intervention of the control group had 139. Both the groups were given the standard conventional treatment for diabetes. And just one difference, that in the intervention group, the TRM meal intake was instituted as a measure, 0.17. The height was 1.58 meters. The weight was 71.1 when we started the study. And the first follow-up, which was done after 6 months, it was 69.5. And second follow-up at the end of 1 year, 67.7. Finally, the third follow-up, 67.2. So we do note a decrease in weight, which was statistically significant. If we look at the control group, we started with 76.6 of a mean weight in all our patients, that was mean weight. And then finally, we came down to 73.8. So here also there was weight loss, and like I said, that both these groups of patients were also being given medication. We did not restrict medication. So we only can do TRM along with medication because then we have an ethical issue that it's a diabetes patient, we're not giving medicine, this is not going to be possible. So we have to do it along with medication, so this kind of becomes a confounding factor for our study, and that is a limitation. So BMI, if we talk about the BMI in the TRM group, it was 28.7, it came down to 27.8. Neck size or neck circumference rather in centimeters, it was 37.2, it decreased to 36, which is insignificant. The waist size, 96.9 centimeters, it came down to 91.7, which was significant. The hip size, 106.4, it came down to 101.3. Something interesting that we noted, that the blood sugar fasting and blood sugar postprandial, also HbA1c, in which we were majorly interested. So the blood sugar fasting 160.1 milligrams per DL came down to 126.2, which is a very good reduction. And if you look at the blood sugar fasting in the control groups, so that was 164.1 the mean level, it came down to 134.8. So here we can see that probably this was due to TRM because drugs were being given to both the kind of patients. Postprandial showed a even major change, 243.3, it came down to 148.7 over the course of 1.5 years. And in those patients who were in the control group and not on TRM, their postprandial was 247, it came down to 205.4. So one thing that I missed out is that in our TRM group, we just gave them one clear instruction that they were supposed to be having dinner at 7 p.m. not later than that. And in the control group, we told most of our patients were having dinner post 9 p.m. So when we used to fill out the questionnaire, when we used to write the daily routine of the patient and what they generally have, so we made a clear mention of that those people in the TRM group, they were supposed to be having dinner at 7 p.m. for at least 5 days a week. So even if they did not adhere to it on the weekends, which they mostly didn't, we didn't exclude them from the study. we continued with them that at least they were doing it for 5 days a week. So we kept on including them in the TRM. If we go, yes? Post 9 p.m. In the control group, they were having post 9 p.m. In the TRM group, they were definitely having it at or around 7 p.m.
So, if that, can you conclude the dinner because both the groups are having the dinner at different times? So
That was our intervention. That was basically our DLM. That was the only intervention we did. Because caloric intake also we can't change much because both the patients are coming to OPD. They were given a diet chart ranging from 1400 to 1600 kilocalories per day. They had to be following that because that was the physician's instructions. The only intervention we could genuinely make in these patients was time restriction, and also because they were not on insulin, we could do that. We could not do this study on those who were taking insulin, but they would be in hypoglycemia the next day. Again, that would be very unethical on our part. So that is the major leeway that we got, and we used that. So the other thing is that TRM showed very good results in the lipid profile of patients. So we had a hypothesis regarding that, and our results do confirm to it that the total cholesterol went down from 190.9 to 163.3. We could also have looked at the activity levels in these patients.
This is not different. 190 and 160 to see the right hand side is it. They are not different.
Yes.
They are not statistically different. They are not. So you don't say they different. Those well, it's such a huge standard that they are not different.
Yes. So, and in the control we see that it was from 162, it actually increased to 183.2. This is something again we could attribute it to their exercise, or we could attribute it to probably compliance in terms of medication. There are many factors here, but this is what our basic study found. So over the course of 18 months, as we compared the TRM with the control group, we had some significant observations. In the control group, there was no significant change in the anthropometric parameters of weight, neck size, hip and waist size. Now barring an HDL, no parameter registered a significant change in the control group. And in the control group, the BMI, the blood sugar fasting and the PP, HbA1c and HDL did register a significant change. And in the TRM group, the waist size, LDL and VLDL, they did not register a significant change. So the parameters of blood sugar fasting, TP, HbA1c, anthropometric parameters all registered a significant change. And in the TRM group, the biggest change was noted in the lipid profile parameters of total cholesterol, triglycerides and HDL. So this was a very basic work, and thank you so much for your patience.
Cholesterol, you are saying it reduced. Overall, statistically, it may not be significant, but can you figure it out in terms of the percentage? The C is not there. Here he said he hates percentage. But how many percentage in population of the patient actually it was reduced? Because you have both the types of the patient at the end.
Yes, sir. So I am not worked out.
Okay. The second thing is that in TRM you are restricting the last meal time.
Only
7 or 9. What about the first?
So we did
The
keep
first
a
food they are taking
yes,
in the morning. That will
sir.
also be very important.
Yes, sir. Yes, sir. We did keep a record of it, but I won't make such a big claim that we monitored every time that they were having food. But what we did do is that every week, and in some patients every 2 weeks, wherever it was possible, we did maintain their routine. Like first thing, what do they have in the morning? So it was like a very basic questionnaire that we filled. And we even noted that were they having a small toffee also, we noted that also. Only that was in our hands most of the time.
Yeah, because you are not doing any control.
Yes, sir, it's
Yeah.
not, and compliance is very difficult.
Because in time restricted to the schedule, the total duration to which
Yes.
food is available is important.
Important, yes, sir. So we were basing.
In other words, the duration when the food wasn't available. So the only thing which you do, the last meal and first meal is zero. Because experimentally it has been shown that during that period you eat as much as you want or whatever you want. But the last meal and first
meal.
So if you, the second thing is your range of age is really huge.
Yes.
So if you have enough individuals, you can classify
Age-wise.
age-wise.
Yes.
And that's why your database will be less messy.
Yes.
Because you can't expect metabolic rate or metabolism in 25 years
Yes.
and 60
60
years of
yes.
age the same.
Yes.
Do you find any gender difference?
Gender difference, I didn't look for it mostly, but I didn't look for it. Gender difference. This is just the basic parameters. Thank you. Thank you so much.
I would now like to request Saul Jaiswal to please present his presentation.